Edition newsletter. There are QR codes in the lobby, and it's a great way to follow the reporting of our journalists here in DC, like Riley. Just wanted to thank you again for joining us today, and we hope you enjoy the conversation.
Director. Hello, everyone. Thank you for showing up on this very, very beautiful day here in DC. It's great to have you. I see a lot of familiar faces, and among them, the director of the CDC herself, here in person after Friday making major news on COVID isolation guidance. We saw a shift in which now people who are no longer or seeing their symptoms abate and are fever-free within 24 hours can return to life, to office, to normal activities. And I want to start there with the hard news. It was a really exciting day for many, and for others, it drew some criticism, some skepticism, some concern about whether or not the guidance would encourage people who are still transmissible to be in places with others and potentially. I want to ask, how do you respond to that guidance, to the criticism, to the guidance that has emerged since Friday?
Well, first, great to be here. Thank you, Riley, for having us, and to Bloomberg for this event. Maybe to step back, what we were trying to do with the guidance overall is align across COVID, flu, RSV, respiratory viruses in general. The good news is we're in a different place, and that's after a lot of hard work. And we're seeing hospitalizations for COVID go down. We're seeing deaths for COVID go down, even as we saw high levels of viral activity this past year. So we were able to see in our wastewater, now we have this national network of wastewater data that we can look at. We saw a lot of virus circulating in our community, but we saw that continued trend of decreased hospitalizations and deaths, and it held through this entire season. You know, actually, we went to look at this guidance last summer and said, could we move in this direction sooner? But that, you'll remember back then, we saw one of the largest changes in the COVID virus that we had seen since the Delta variant. And so we wanted to make sure that we could sustain the trends that we were seeing. And the good news is we did. And we really wanted to give folks simple guidance that they could remember and that they could follow. You know, we all heard the feedback about CDC. Please give us things that are easy and simple to understand and follow. So we hope we met the mail on that. And really what this is focused on is helping people focus on the things that are going to keep them out of the hospital and protect their lives. And that's vaccination. It's why the first core strategy we recommend is vaccination. Over and over and over, we continue to see vaccination be the thing that will save someone's life. Oh, the mic isn't working. Okay.
Can we hear her now?
Can we hear now? Hello? Nope. Hello? Okay. Oh, there we go.
There we go. All right.
All right.
Wonderful. We're back in action.
Well, I don't know where we left off.
Vaccination, you were
Okay,
saying.
so vaccination is really the core strategy. So I know there was a lot of focus on the isolation guidance, and I want to get to that. But I just wanted to make sure that folks knew that what we are really trying to reorient folks are the things that will save people's lives and, frankly, reduce the risk of long COVID at the same time. So, and that was really about vaccination. We need to see everyone get an updated flu shot and an updated COVID vaccine. We also shared on Friday that we expect and anticipate there's going to be an updated COVID vaccine coming this fall, right? So plan now, right? It's March, so you can think ahead. When you're going to get your flu shot in the fall, you're going to get another updated COVID vaccine. And the reason for it is because this virus continues to change. That's okay. We can stay one step ahead of it. We have the tools to do it. We just need to use them. So FDA, CDC has started that process just like we do with the flu shot. We've started that process to update the COVID vaccine already for this fall. And so we just want folks to, again, already start thinking about that.
So you're already working with Pfizer and Moderna, and you've recently updated this guidance. I wonder, as you think about vaccination next fall, if we could see any changes around guidance there. For example, some countries around the world do not recommend that children get vaccinated. They see them as low risk. Is that something that could change, or is vaccination guidance staying tried and true?
Well, you know, I'm glad you brought up kids and COVID. You know, I think we definitely see COVID impacting our kids less, but actually the places where we see the most hospitalization are kids under 5 and those in our elderly community. So it's starting to have a pattern similar to flu, where younger kids, they just have smaller bronchioles in their lungs, right? They just have less of an ability to fight off some of these viruses. So actually, we want to make sure we're still protecting our kids from COVID and from flu. So you're going to continue to see us look at that data, make sure that we are obviously looking at that all the time, but I don't anticipate changes right now. Of course, we go through that process. We look at the data all the time, so I never want to get ahead of our advisory committees and looking at that data, but we have been still seeing kids get pretty sick from COVID, and we want to make sure they're protected.
And while we're talking about the higher risk individuals, the immunocompromised, older Americans, children, pregnant folks, they have questions. They have questions about what this means for them as they go back to work and have concerns about the person sitting beside them. So how do you reassure them in this moment?
Well, one, I want folks to know who are immunocompromised, our older Americans, they were top of mind as we did this guidance. These are folks who are in our own lives, my own into these categories. So I was certainly thinking of them as we went through this guidance. And we think that simplified guidance that people can follow actually benefits all of us. But in addition, we did put out some special guidance for folks who are immunocompromised, folks who are older, because there are special considerations. They need to take additional precautions to help protect themselves. And we also need to be thinking about who are we around. So you'll see in our guidance that we do say, think about yourself and your own risk, but please also think about who are you around. And when you don't know, think about using layers of protection when you don't know everyone's health status around you. Make sure you're doing everything you can. Again, that's why stay home when you're sick is so important, right? So really try to keep your germs to yourself and not sharing them with folks who might not be as strong and able to fight them.
And should we see a more dangerous variant emerge? Are you flexible? Are you willing to change that guidance again? And if you were, can you put the genie back in the bottle? Will Americans be willing to go back to stricter protocol again?
Well, I think we're being clear that this is the best evidence that we have right now. This is what we know in this moment. We wanted to see those trends hold through another season. We feel good that we continue to see that. But yes, this virus is constantly changing, and as I said, changing faster than the flu virus. So it is possible we might need to be back here. I hope not. I think if we continue to stay ahead of this virus, that we continue to update and make sure that we are not resting on our laurels, right, and saying, oh, and putting it out of our mind. If we keep using these simple things like get vaccinated, stay home when you're sick, simple prevention things, don't forget treatment, those are the things that will allow us to stay ahead of the game. But we need to make sure that we don't get complacent.
So no longer in a public health emergency, and COVID is more on the playing field of flu. What are the health threats that you are concerned about or monitoring for right now in the world of respiratory viruses?
Yeah, so of course, there are a lot of health threats in the world. Some of them are infectious disease, some are not an infectious disease. And actually in 2024, I hope folks can see parts of the CDC that they've never seen before. They got to know CDC because of COVID, but there is a lot that the CDC is doing here domestically and globally to protect health and improve lives. I just came back from a trip to Asia. I was in Cambodia, and they've had a few cases of avian flu. So this is flu from birds. It was from contact with infected poultry. And what is impressive is that CDC has been working there for 20 years, supporting the ability for the Cambodian health system to rapidly respond to seeing those cases and make sure we're not seeing human-to-human contact, which we are not, which is good, but that we're also understanding the genomic sequencing that's going on. They were able to turn around a sample and diagnose the kind of avian flu in 7 hours in Cambodia, right? So they're doing great work. We need to do that globally. So if you're saying, what keeps me up at night? It's things that are respiratory viruses that spread easily, that can have high severity of disease. And avian flu, unfortunately, at least in some of the parts of the world, can have a mortality rate of 50%, right? So high mortality, something that's easy to transmit. That's what keeps us up at night, but just want folks to know that you don't need to worry because CDC is there doing its job. But we need to sustain that work, right? We need the funding, we need the infrastructure to be able to protect Americans here. We have to be doing that work globally, right? In Cambodia or in other places, so we don't see those viruses and bugs come here to the United States.
CDC has a broad global footprint, but it isn't everywhere at all times, and we really rely on data sharing between other countries. I wonder how you think about that in a time of geopolitical conflict, particularly with China in the wake of the pandemic, also with Russia. How do we ensure that we're still cooperating and sharing data around the kinds of viruses that are being spotted in genomic sequencing given those tensions?
Well, there's a couple of things. One, we're doing our work here in the United States to understand what's happening around the world. In terms of genomic sequencing, we actually do wastewater and genomic sequencing at airports. And so we both have travelers who are returning from international destinations. They can volunteer. So if you are returning from an international flight, please volunteer to get your nose swabbed. It helps us understand what might be moving around the world. We also do wastewater sampling at the airports as well. So that gives us some information. Certainly we have a lot of scientific around the world, and that's really important. So I think we've all learned how interconnected we all are through the pandemic, and we have to find ways to be able to share information and in order to protect each other. So we'll keep up those efforts. We just opened a regional office in Tokyo in Japan. We know that region of the world is incredibly important to make sure we have visibility. So we're doing more and more work to build up our efforts. Again, why CDC needs to be an asset for this country to protect health, right? To protect our national security. I think we all saw in COVID how a virus can destabilize our normalcy. And so needing to invest in that security is incredibly important, and CDC being the quarterback of that work.
So you're not overly concerned about scientific diplomacy being at risk in this moment?
Well, I think we always need to build more, and I think that is where I think we're doing a lot of important efforts. And so I think it's important for folks to understand that the CDC needs to not just do its work domestically, but do it globally. And of course, we have other partners who do that work. It's a team sport.
Shuttling back domestically, over the course of the pandemic, plenty of polls told us that Americans had lost some semblance of faith in the CDC or lost trust. You've come in at a time to rebuild that trust. What's it going to take to really get Americans back on board with the agency's recommendations again?
Yeah, so, well, one, I'm pretty proud of CDC. During my, I think, 8-9 months that I've now been in the role, I hope you have seen the CDC operate differently, communicating faster, more transparently, clearer, simple, actionable guidelines that you can follow. So transparency, I think, is top of mind, and making sure that communication is simple. You'll see in the next few weeks a complete overhaul of our web presence. There's a lot of information up there. Not all of it is used on a daily basis. We really want to focus people's attention on what are the most important things they need to know. So you'll see a whole new web presence from CDC in just the next few weeks here. So transparency is certainly number one. But I'm also an operational person by my nature, and I think a lot of trust building is in delivering, not just saying the words at the right time, but actually showing people, showing up in their community, helping them get access to a vaccine, get access to a test, like protect folks from health threats, whether it's, the fact, I'm from North Carolina, so I was very proud of North Carolina, was the folks who found the lead in applesauce just a few months ago, right? Show folks how public health is working for them, and that connect it to their real lives. So it's operational execution every day. And then it's relationships. We can't protect health alone at the CDC. We have to be the quarterback of that work, but that is a team effort, not just across the U.S. government, but private sector, right? I think we all learned that. And so make sure we're maintaining and building relationships as we go. So that's the roadmap for me, right? Transparency, operations, and relationships. And we try to embed that in everything that we're doing.
There's a real deficit of public health workers in state and local health departments and beyond, one that began pre-pandemic and was really exacerbated throughout that time. I mean, how do you address that when you're talking about building those partnerships? You need boots on the ground, and those boots are fleeing.
Well, I think there are some core capabilities for being able to be ready to respond to health threats that we need. Workforce is absolutely one of those, right? We need folks who are trained to be able to be deployed rapidly, that have the scientific expertise. And, actually CDC has a ton of training programs, and we want to see those even expand more. I'm hopeful with folks getting to know public health in a different way, in a very real way, just like, when there were certain TV shows, people went into pathology, forensic pathology in a way. So I'm hopeful, public health is cool. And so we hope to see more young people coming into the field. I think that will be great. But again, it's not just the workforce. You need the underlying data capacity and infrastructure to make that possible. We need the diagnostic and lab capability to make that possible. And you need the infrastructure to do rapid response. Sure, you need the human beings, but you need the structures and response capabilities to be able to do it. So we're very focused in 2024. That is our top priority, being ready to respond. Trying to focus on in 2024.
Shifting beyond COVID, I want to talk about rapid response to another crisis, the opioid epidemic, which drug overdoses broadly are taking more than 100,000 lives every year, the vast majority of them now from fentanyl. This is a core part of CDC, but one that people haven't been paying attention to perhaps for a while. Are new public health measures needed? Is the treatment and prevention strategies that you've had, are they been effective? Do you need vaccines and treatments?
So I think improving mental health is very much a priority for us. If we had 3 priorities, one is ready to respond. Number 2 is improving mental health and specifically reducing overdoses and suicides. And then 3rd, supporting young families. So this is a big priority. If we were the quarterback of readiness and response in this space around overdoses, we're a critical but important team member, right? There are a lot of folks in this space, particularly on the government side, whether it's SAMHSA or HRSA or CMS, all at HHS doing this work. But what CDC specifically brings is our ability to bring expertise, right? So data that can really help folks understand what is happening in their community, because things are changing, right? So we made some improvements, we gained some ground, 2017, 2018, 2019. We were seeing reductions in opioid overdoses, largely because we were seeing changes in prescribing patterns related to the pills. But then what happened, we saw a lot more fentanyl come into the system. Again, our data showed that we were having about the same number of overdoses, but the ratio of those that were fatal overdoses were going up. And we're seeing a lot of fentanyl mixed into other kinds of substances. And it was in a lot of our data and then the evidence generation on top of that have allowed us to say, we have to shift again. We need to make sure that we're responding to the kinds of crises we're seeing right now. So we need to be connecting people to care and recovery services when they're in the midst of an overdose. We know that is a best practice. Those are the kinds of things that CDC is investing in.
Do you anticipate that the rate is going to continue to rise, or is the plateau here to stay?
So I would say the rate of increase is slowing, so that is good news. I don't think we're quite ready to say yet that it's plateau, but it is hard work to even get to a slowing, but I'm hopeful that we can continue to see that. But again, this is a team effort here, but I think the data expertise that CDC can bring is part of the foundation here. I was just in Birmingham, Alabama last week, focused on seeing the CDC investment there, and we're able to support one of those best practices that links people to care, right? Great work going on in the emergency rooms and with treatment providers, but they were siloed, right? And so one of the ways public health can help is be that glue and that intermediary between, again, using our data to help the right populations make sure they're getting those linkages to care.
There's been a lot of capital that's come from settlements with pharmaceutical companies and distributors around the opioid epidemic, but concerns that capital isn't being distributed to those who have been impacted directly. Is there a better way that the U.S. could be, and state and local health departments could be appropriating those dollars to more directly aid the work that you're describing?
Well, I think we definitely want those settlement dollars to go to the evidence-based practices that we see and to use some of the CDC data to make sure it's going to the pockets and populations that we know are at highest risk. So I think there are a number of states who are really working hard on this, but I think we can do even more. So stay tuned as we do even more work to give more guidance, particularly around those settlement dollars, help folks know this is a good investment, effective. Maybe this is lower value. Maybe don't think about those kinds of efforts. So stay tuned for more.
We'll stay tuned. You mentioned Birmingham. The week you were in Birmingham was the same week that we saw the University of Alabama at Birmingham decide to stop offering IVF treatments as it examines a ruling from the state Supreme Court around the personhood of an embryo. I wonder how you see that decision affecting parents across the country who are hoping to get pregnant, have a family, and what's the CDC looking for in the data from here on out about that impact?
Well, first, our third area of focus is supporting young families, and certain, chief among them is making sure that women have access to reproductive health services and the range of those. It's really important. Gets pregnant when she's ready to get pregnant, that she has a healthy pregnancy, and a ton of CDC work going into making sure healthy pregnancy as well as postnatal health as well. And so, look, making sure folks have that range of health services is really important. We do continue to track birth outcomes and health status of mom, and we support maternal mortality reviews and have for quite some time in 44 states. And actually, just to put a plug in, we are expanding that to every jurisdiction. So we hope to have maternal mortality reviews in every state. We do that because we need to understand root causes of why moms are dying related to childbirth. And what we have found is 80% of them are preventable. And so we can do better. We have the best practices, we have the data. So again, I think that's where CDC and our data can really shine. But again, important to have that full range of reproductive health services so that mom can be healthy and babies.
That figure of 80% preventable deaths of mom, as I understand it, that's from 2017 to 2019, I believe. So pre-pandemic, pre the overturning of Roe v. Wade. Are you tracking that data in the wake of Roe v. Wade? And if so, what are you seeing there?
Well, we definitely continue to track data, but I don't think yet we're at that place where we can compare pre and post. I think we're still getting in that data right now. So again, stay tuned. A place where CDC, I think, just continues to be having that underlying data expertise that can bring to bear to these issues.
Moving quickly on data was one of the kind of mandates of your predecessor, former Director Walensky. So excited to see what data comes, and you'll have to share with all of us here. Wanted to switch to maybe the buzziest subject in healthcare right now, which is weight loss and Ozempic. Just because CDC plays a different role here, you track the obesity epidemic and play a role in terms of behavioral changes and equity changes. But what do you make of the Ozempic craze, and what role can CDC play here?
Well, we're at the very beginning of this, so I think this is going to play out in a bunch of different ways. But we continue to track data, and I think we're going to see what impacts it will have, and is this going to be a medicine that someone is on for a long period of time? Is this something that is 6 months to 2 years, or is this a forever? And then what impact does that have on their underlying health overall? Lots of questions. Don't have a lot of answers, at least from the CDC side yet. I know others are looking at this from their own vantage points, whether it's a payment issue or an equity issue. So more to come on this as we continue. Again, this is why I hope folks understand CDC's important role that we can play in that data and expertise. And then, just looking at the data, be like, what are the best practices here? So too soon to weigh in yet, but we will definitely be tracking and understanding how these things will impact obesity, heart disease, diabetes as we go forward.
Beyond tracking the data, is there a world in which CDC would push for greater utilization of the products?
Potentially, depends
Yeah.
what the data shows, right?
Yeah.
Again, and I will say, these could be medicines that work well for others. It doesn't work for everyone. So I think we'll never get away from sort of the tried and true things that we have worked on in terms of overall healthy habits and lifestyle changes and others. So, I think obesity is always going to be a multifaceted challenge for everyone. But it may be another tool, but I think jury's still out on that and data still to be collected.
Looking forward to seeing that data too. We are in an election year, and we're here in our Washington bureau. It's an interesting year for you because should former President Donald Trump succeed, that could mean potentially an end for you in your role. You also will be the first CDC director to face Senate confirmation next year. I mean, how are you thinking about the Senate confirmation, the presidency, and what does that leave you wanting to accomplish given there's potentially a tenuous road ahead?
Well, I'm not thinking about it in that way. Obviously, I'm thinking about a 4.5, 5-year horizon here to be able to do our work. But I also know that we build relationships on both sides of the aisle. We're doing this work. This is about data and evidence and investment and protecting this country, no matter who the president or party is at the top. I'd love to be able to continue in my job, and we're definitely cultivating relationships. Trying to understand issues on both sides of the aisle, of course, and I think that already we are making a fair amount of progress. So I look forward to being able to share what we've done with the Senate when I go up for confirmation next year.
Any specific goals through the end of the year that you're trying to accomplish?
Absolutely. So we're focused on 3 areas, as I mentioned, that readiness and response, and making sure that core infrastructure is ready. I can't do it alone, though. This is where I do need Congress's help to make sure we're continuing to invest in data, in lab, in our response capability. There are some authorities that CDC does not have, that other response agencies across the government do, that things that we can solve together by reauthorizing PAPA and some other pieces of legislation. So that, for one, you heard about the overdoses and suicide reductions and supporting young families. I definitely want to make sure we're maintaining our vaccination rates in our kids, maternal mortality we also touched on. So we have a lot going on. And then I'd say there's internal work at CDC. Like we have been working really hard to be different. And I hope you're seeing some of that. Some of that internally facing work isn't always seen, but the communicating better and differently, but also just operating as one team. Often we were very disease focused. So teams would sit pretty siloed. And sometimes our budget reinforces those silos. So we're really trying hard to work to plan as one team, to execute as one team, to make decisions as one team. So that's a newer space, but I'm really proud of where the team is headed. So all those things are happening this year, but you can't do things in just one year. This is has to be a sustained effort to get real change within an organization. So I'm looking forward to it and another 4 years.
The last day of the former director, Walensky, I was with her in Atlanta, and she said the most difficult thing about her job was the way politics had affected it, that it made it really hard to do what she needed to do as CDC director. Do you think we're still in that moment where politics is affecting public health? And how is that affecting you in your capacity to serve?
Well, look, I led the COVID response in North Carolina, Purple State. I worked for a Democratic governor, but we had a supermajority of Republicans in our legislature. And I was really proud of how we navigated the pandemic, where we got 99% of our seniors vaccinated. The governor was, we never had a place where he was stripped of emergency powers. There was mutual respect there, and that is what I bring to the job. I do think also time heals, and I'm hopeful that as we're moving into a different place, folks can see we're focused on learning those lessons, that we're trying to be the asset that this country deserves and needs to be. But it does mean we had to change at CDC, and I hope folks are recognizing that work as we go forward. So I think we are in a different moment, but I also recognize, and this has been true for the life of CDC, the folks who fund us are elected officials, right? And so that will always be an element of our work. And they represent their communities, and communities have different perspectives on how to think about protecting health. And I think that's fine for us to have that dialogue. But we're going to stay focused on the evidence that we can bring, on the tools that can save people's lives. And I think that's where we can get consensus.
Well, I have plenty more questions, but I know that we have 15 minutes for audience here and a lot of press in the room. So if anybody has a question, please raise your hand and we will direct a mic your way.
Hi, Dr. Cohen.
Hi.
Am I on here?
Yes.
So I want to ask you about the measles outbreak in Florida. The Florida Surgeon General has contradicted the CDC's advice on COVID boosters, doesn't recommend them for people under 65, and also has said he would defer to parents on sending kids back to school there. So I have 3 questions for you. 1, does the CDC have people on the ground in Florida? 2, what do you do when a state official contradicts your advice? And 3, have you talked to him?
Well, so a couple of things. One, I want to say that the local health folks in Florida, in Broward County, have been doing a lot of good work here with the school district. I believe there's 8, 9 cases. They've been communicating with parents. The good news is the vast majority of kids are vaccinated, which is great news. If kids are vaccinated, they're protected from measles. And so we've been working well with, and I will say that then the National Organization of State Health Officers was the one who, has really been clear about what have been standard practice public health guidelines related to measles. And I appreciate their being the ones to help their fellow colleague understand where practice should be. And I think there's been plenty of experts and others who have shared how we can protect our kids. So I'll leave it there. As far as vaccinations, again, another place where time and again we continue to see the data show that vaccines are safe and effective. And I hope with Friday's announcement that folks are really seeing that we're trying to get folks to focus on the tools that are really going to save lives, and that continues to be vaccines. So I'm hopeful for more and more alignment in that space. And when I talk to folks on both sides of the aisle, whether it's physician members of Congress or others, I hear a lot of agreement along those lines.
Hi there. When it comes to federal oversight of IVF, federal rules require clinics to report some data to the CDC, like patients' pregnancy rates. However, they're not required to report accidents or errors. I understand that the CDC has some purview over CLIA, which is the statute that oversees some aspects of IVF, like testing, for example, but the statute does not cover embryology labs where the handling of embryos and eggs occurs. Given the industry has expanded rapidly over the last couple years, and these rules were first established way before that happened, is the issue of tracking error in IVF, given the CDC is such a data-driven organization, an issue that the agency is looking at, or even extending CLIA to cover embryology?
So I'm going to wear my former hat. So CLIA is overseen by CMS. So it's not CDC. So I don't know the specifics, but I could think back to my CMS brain from a number of years ago about.
I believe it's in partnership with the FDA, though, right? With the FDA, CMS, and the CDC.
So we should follow up offline. So the CDC does track some of the outcomes related to some of this, but really the standards and the quality and the certification are through CMS. FDA does the lab test standards. Anyway, more than we probably want to get into here, but I hear your question of understanding how do we make sure our rules are keeping pace with the changing industry. So I think we can follow back up on that. I don't know that it's fully within CDC purview, but I hear you're asking, and we'll try to follow up.
Got a couple questions over there.
Hi, Director Cohen. Thanks so much for taking our questions. I was wondering if you had a timeline update for strain selection for an updated COVID shot this fall.
Great. So yes, we are already doing the work to understand the strains that are out there. FDA did announce that their VRBPAC, which is the body that will do the strain selection, is going to meet on May the 15th. Our immunization advisory committee will meet in June. And we anticipate that an updated vaccine will be completed by manufacturers. And of course, they have to go through a regulatory process, so I can't say an exact date, but folks should anticipate when they're getting their flu shot, they're gonna get an updated COVID shot as well. So we're on that timeline, strain selection probably in May.
Any specific strains that you're following closely right now or concerned by?
So look, we're still looking at the JN1 variant. So 286 was the biggest change to the COVID virus last August. And then we saw JN1 actually make 286 even more transmissible. So we're certainly looking at that family right now, but that's why we wait as long as we can, because it is a bit of a, we have to select just like we do for a flu vaccine. And you want to make sure you're seeing as many of the changes so you can get the right strain so your vaccine's as effective as possible. So May is about that time, then they'll go into production. So again, starting to see a similar pattern to developing the flu vaccine as well, but I will say COVID changing faster than flu, so we're still, it still has not slowed down in terms of its amount of.
Over here, yeah.
Thank you so much for being here and for sharing your insights, particularly as it related to a lot of the surveillance programs, the wastewater surveillance programs and the traveler genomic surveillance program that you had highlighted earlier. This particular program was set up during the pandemic, and it's one of those programs that doesn't have a ongoing part of the CDC base appropriation. So I would love to know what your thoughts are on this particular program and potentially others that were having tails, and it's as you look toward 2025.
Great question. I think there are a number of capabilities that we were able to develop over the course of the pandemic that we now are utilizing for other public health threats. So we started them for COVID, right? Wastewater was just COVID oriented, and then we add flu and we RSV, where we can add actually Mpox to that as well. And then imagine, other health threats. I think and we want to be doing as much sequencing again to understand what's going on in the world. So this is where I go back to working with Congress on these infrastructure, like this critical infrastructure that we need to keep our country safe. Just like we need to protect our electricity grid, we need these kinds of infrastructure, wastewater, genomic sequencing capabilities that in order to keep us safe and protected. So that's the conversation we're going to be having with our colleagues in Congress on those core capabilities. Data and the genomic sequencing and others are certainly one. The diagnostics and the lab capacity and other. Workforce, as was mentioned, and then our ability to rapidly deploy teams when we see health threats or outbreaks. So those are the ones we're going to continue to focus on. It's both domestic and global.
Saw from Julie.
Hi, thanks, and thanks for being here. You've talked about one of your priorities being preparing for the next pandemic. I think one of the things that we learned from COVID is how little the public really understands about public health and about the scientific method and about how sometimes advice changes based on things that are changing. Is finding a better, clearer way to communicate that sort of both the uncertainty and why sometimes recommendations change part of what you're preparing for the next pandemic?
Sir, I think we certainly learned a ton about how to communicate better and differently, but also I think there is peacetime communication and then emergency communication, and I think they can and should be different, and both in terms of who's communicating, how often, what does that look like, and so I think we are trying to capture those lessons learned, right? So in an emergency, I certainly have a strong lived experience on how to think about communication. I think it needs to be centralized and coordinated, it needs to be simple, and it needs to be often. In North Carolina, we did 180 press conferences in a year and a half. So every day, 2 o'clock, Governor and I on the stage, right? Even when we didn't have a lot new to share, and it was like, here's what we know today. That might be different. I'll be back here tomorrow, and everyone could trust that we're going to be back tomorrow to answer the questions, and it wasn't a black box. But it was also really hard work to boil down really hard scientific principles into something that can be digestible in just a couple of minutes, particularly when you're learning, right? The world watched us learn in real time. But I think, we've all experienced that now. What I worry about is that we'll forget, what that felt like. And I do think there's a bit of, Monday morning quarterbacking, everything, it was a crisis. We didn't know the things we know now. If we knew them, it would have been a very different circumstance, right? We didn't know how, the virus was, all the dynamics of the viral transmission at birth. We didn't have any of the tools that we have now. That's why we're in a different place, which is great. Hopefully we're capturing those lessons learned. I do think in peacetime, our communication can and should be different. You should hear from a lot of different voices. You should hear from more of the scientific experts so that we can get lots of different voices out there. In an emergency, I feel differently about that, about centralizing communication to get clarity and one person talking about both the science and the execution, the operations at the same time. So we're trying to think about how to memorialize and embed those, even though we are in peacetime now. I don't really want to practice again, so for a while. So I hope you will only see peacetime communications for.
Dr. Cohen, I wonder how you weigh or explain to people how you weigh the science and what the public will actually follow. That seems to be a key question as you roll out this new guidance. So where's the balance?
Well, it's always thinking about risk-benefit ratios, right? And so early in the pandemic where we saw so many people get hospitalized and we all watched New York's healthcare infrastructure basically implode and not be able to sustain itself in a major metropolitan city, right? Those were places where things we had never seen in our lifetime. So, right, we knew that from a risk perspective, there was so much risk. And so and we didn't have the tools we needed. We didn't have vaccines. We didn't have treatment. We didn't have a lot of the knowledge we have now. So that changes over time, right? But when you start, we didn't have a population that was exposed. So all along the way, you're doing these kinds of recalibrations of what are the risks, what are we seeing in terms of hospitalizations, death, burden on the hospitals, burden on our healthcare system, other kinds of sequelae like long COVID, right? How do you factor all of that together to then understand how to make decisions? Then you start to then you have testing, then you have treatment, then you have vaccines, then you have, right? So as you add on more tools, as well as see different things happening with our overall population immunity, you're able to make different decisions. And so the good news is we're in a place where things are different. We continue, though, to need to stay ahead of the virus. That's why we sort of aligned this across all respiratory viruses so people can have that same aligned guidance that they can remember, they can execute. And the top thing I hope people take away is get vaccinated, get ready this fall, updated COVID shot, updated flu shot.
Got a question in the front.
Is there a danger to the idea of parent choice, like that vaccine should be a choice for a parent?
Well, there's a few things I want to tease out in parent choice. One, I think it's fine for parents to ask questions. I want them to ask questions about what's going on with their kids' health, talk to their pediatricians about concerns. They should also know that for routine childhood vaccinations, we continue to have very, very high rates of vaccination, which is fantastic. Even for measles, which we saw like just a little bit of decline, we're still seeing 94% of kids have a measles vaccine, which is good, but we'd like to be at 96%, right? We're at 94. And so there's always more to do. So I want to separate that out from a COVID shot, a flu shot, which that was where we see lower rates of uptake. So I want to make sure parents continue to do those routine childhood vaccinations, that are for viruses that don't change as much, right? So you can get that one measles shot or the series of measles shots and then be done for your kid. But with COVID, we know that the virus is changing so much, and with flu. But with flu, we know that kids are very susceptible. They get sick. And so this is where it's good for parents to ask questions, but we also want to tell them the risks of doing nothing. Means that kids get very sick, could be in the hospital, could be in the intensive care unit, and we have the tools to protect it. What I try to help parents with is I'm a mom, my daughters are 9 and 12, and I say this often, and let me tell you what I do for my own kids, right? My own kids got an updated flu shot and an updated COVID vaccine. Because you can hear all the data in the world, but sometimes it has to be personal. Doc, what do you do for your own kids? And I think it's okay for parents to ask those questions. We want them to talk to their pediatrician, but hopefully make the decision to take advantage of tools that are going to protect their kids.
Final question from the audience.
Thank you, and thank you so much for being here. And you mentioned and talked a little bit about operating as a central and one team. Can you maybe explain a little more about how that works inside the HHS interagency and how, especially in pandemic preparedness, how the larger HHS and maybe DoD interagency are all working together to be prepared to respond to the next pandemic?
Great question, so important, because we all see different pieces of the puzzle and we have to work together as one team. So just within HHS, right, NIH does a lot of the seed research on diagnostics and on therapeutics that feed our ability to have the vaccines that we have and have the therapeutics. ASPR is the one that is thinking about having the stockpiles, right? Do we have the right PPE? We've all learned about our supply chains and PPE and like all of that more than we. ASPR, owns that. CDC, the underlying data to pick up something that might be abnormal, respond to it, what's happening. And so we need all of the pieces. And I'm, really, I've been in government and worked in a number of places. I do see us moving in. I think we've learned a lot of lessons and the importance of that teamwork. But what we have work to do still is to build the systems that talk to each other, that allow us to, and again, they've made a lot of progress. So it's not like we're starting this from scratch, but we have to continue that investment to make those aligned systems, the data infrastructure, that lab capacity, and make sure that there's the visibility across all of these like very smart, very sophisticated programs, and make sure that we have the visibility to have that all work together. I think it's good now, but we also have lots of leaders who just lived through COVID, right? And so what we need to do is make sure that gets institutionalized, so when leaders move on because they take other jobs, and and folks come in who didn't live through COVID, that we still have that level of collaboration. It's not the informal relations, but it's some more formalized, and I think we're working through making sure that happens. And data structures, lab structures, those are the things that endure and that we're trying to focus on, make sure that they're there.
Well, thank you, Dr. Cohen, for covering so much ground in this conversation. Really appreciate you taking the time to answer the questions. And if you give us a moment, thank you all for joining us. We are going to head out there for a reception, and Dr. Cohen's going to join us for a few minutes. So join us, and we'll keep chatting. Thank you.